Good morning, students. Let us start our lecture. The theme of the current lecture is drugs influencing blood coagulation and thrombocyte aggregation. Classification of these drugs, you see, we distinguish first antithrombotic drugs. These are anti-aggregants and anticoagulants. Among anticoagulants, we distinguish direct and indirect subgroups. Second group, procoagulants, promoting coagulation. And third, agents affecting fibrinolysis, fibrinolytic system. Activators and inhibitors. Activators and inhibitors. First of all, thrombus is a clot that adheres to a vessel wall. Difference in between thrombus and embolus. Embolus is an intravascular clot that floats in the blood. Floating in the blood. This is embolus. We distinguish white thrombi and red thrombi. White thrombi or platelet-rich are formed in the high flow rate and high shear force environment of arteries. So white thrombi are arterial thrombi. Occlusive arterial thrombi cause serious disease by producing downstream ischemia of vital organs and extremities, and can result in organ failure or limb amputation. The use of antiplatelet agent is more effective in arterial thrombi. Red thrombi, fibrin-rich, containing large numbers of trapped red blood cells. That's why red. They are formed in veins. Venous thrombi can cause severe swelling and pain of the affected extremity, but the most feared consequence is pulmonary embolism. The use of antiplatelet agents is less effective in red thrombi. First of all, anti-aggregants. Platelet aggregation is a process that is triggered when a vessel wall is damaged. The essence of this process is the adhesion of these cells to each other. The resulting conglomerate is capable of damping the formed defect. If the defect in the vessel wall is not eliminated by platelet aggregation, then a thrombus begins to form, which helps to stop bleeding. Thus, platelet aggregation is the initial stage of blood coagulation. Individual platelets bind to each other due to fibrinogen molecules, which interact with platelet membrane glycoprotein receptors. You see, GP, glycoprotein 2B, 3A receptors. In a normal physiological state or condition, these receptors are inactive. Therefore, fibrinogen does not bind to them. That is, there is no aggregation process. The activation of these receptors is carried out through a cascade of reactions that begins when the vessel wall is damaged. In damage of the vessel wall, collagen protein, and 1 Willebrand protein factor, are released from the destroyed cells. Collagen interacts with platelet glycoprotein GP1A receptors. The activation of which leads to a decrease in the concentration of CAMP and an increase in the concentration of calcium ions, as a result of which the release of thromboxane A2, adenosine diphosphate, and serotonin from the platelet is activated, which stimulate the corresponding receptors of another platelet. We see that there are receptors for ADP, we call them purine receptors for thromboxane, and receptors for serotonin, we call them 5-hydroxytryptamine receptors. And stimulation of these receptors causes activation of GP2B3A receptors. That is why fibrinogen starts to interact with these receptors and form conglomerates. 1 Willebrand factor 1 Willebrand factor interacts with specific receptors of platelets GP1B receptor, which leads to activation of platelet adhesion to endothelial cells at the site of vessel damage. At the same time, endotheliocytes release prostacyclin, PGI2. Interaction of prostacyclin with specific prostacyclin receptors of platelet inhibits aggregation. On the contrary, inhibits aggregation. Thus, the possible mechanisms of action of antiplatelet agents are following. First, blockade of GP2B3A receptors. Second, blockade of receptors for adenosine. These receptors are called purine P2Y12 receptors. Purine P2Y12 receptors. Third, blockade of thromboxane receptors and a decrease in the synthesis of thromboxane A2. Fourth, Blockade of 5-hydroxytryptamine serotonin receptors. 5. Inhibition of the enzyme phosphodiesterase, leading to an increase in the concentration of CAMP. Sixth, blockade of calcium channels of platelet membranes, leading to a decrease in the concentration of calcium ions. And seventh, activation of prostacyclin receptors of platelet membranes. In addition to preventing thrombus formation, inhibition of platelet aggregation leads to a decrease in blood viscosity, an increase in its fluidity, which leads to an improvement in microcirculation and transcapillary metabolism. Transcapillary metabolism. Modern classification of antiplatelet drugs includes: first group, agents inhibiting synthesis and release of thromboxane A2, acetyl salicylic acid or aspirin, trifluzelum. Second group, agents blocking receptors for ADP, P2Y12 receptors, purine P2Y12 receptors, ticlopidine, clopidogrel, prasugrel, elinogrel, ticagrelor, and cangrelor. Third group, antagonists of glycoprotein 2B, 3A receptors, epsiximab, monefrem, eptifibatide, and tirofiban. Fourth group, agents increasing level of CAMP in platelets, or PDE inhibitors. PDE is phosphodiesterase. Phosphodiesterase is enzyme cleaving CAMP. Inhibition of this enzyme causes increase in concentration of CAMP, dipyridamole and cilostazol. And the last fifth group, analogs of prostacyclin PGI2, iloprost. Indications for the use of antiplatelet drugs. First of all, this is coronary artery disease, acute coronary syndromes, unstable angina pectoris, non-STEMI and STEMI. What is STEMI? ST interval elevated myocardial infarction. If ST interval is elevated, we call STEMI. If not elevated, we call non-STEMI. So, unstable angina, non-STEMI, and STEMI. Third, cerebrovascular ischemia. Fourth, venous thromboembolism. These drugs are less effective, but we use them. And fifth, peripheral vascular disease, obliterating endotheliitis, intermittent claudication, and Raynaud's disease. These are indications for the use of antiplatelet agents. A few words about the drugs. Agents inhibiting synthesis and release of thromboxane A2. Acetyl salicylic acid, or aspirin, is one of the most widespread in the whole world anti-aggregant. This agent inhibits thromboxane A2 synthesis from arachidonic acid within platelets, by irreversible acetylation of COX-1 cyclooxygenase. Ordinary dose for antiplatelet action is 60 to 300 milligrams. Average is 100. More often we use 100 milligram once daily before meals. It is frequently used in combination with other anti-aggregants and anticoagulants such as heparin or clopidogrel. Non-steroidal anti-inflammatory drugs inhibiting COX-1 increase its anti-aggregant activity. Treatment causes prolongation of bleeding time. Prolongation of bleeding time. Trifluzel is used 1 to 3 times daily during meals. Daily dose is 600 to 900 milligrams. Adverse effects appear rarely, can be dyspeptic disorders. Dyspeptic disorders. Second group, agents blocking purine receptors for ADP, P2Y12 receptors. We distinguish two chemical subgroups, thienopyridines and cyclopentyl triazole pyridines. Thienopyridines include ticlopidine, clopidogrel, prasugrel, elinogrel. Ticlopidine is the prototype of this group. It is used 250 milligrams per orally 2 times daily during meals. Possible side effects include diarrhea, stomachache, allergic skin reactions, dizziness, jaundice, bleeding, thrombocytopenia, so on. Clopidogrel, one of the most popular and standard anti-aggregant, clopidogrel. It is used once daily. The dose is 75 milligrams. Among adverse effects, there are abdominal pain, diarrhea, dyspepsia, hematoma, gastrointestinal bleeding, subcutaneous hemorrhage, so on. Prasugrel is used in the dose 10 milligram orally, 1 time daily. Possible side effect, anemia, hematoma, gastrointestinal bleeding, subcutaneous hemorrhage. Elinogrel, strong and fast-acting agent for intravenous, mostly, sometimes for oral introduction. This is very potent, used in cardiologic surgery. Cyclopentyl triazolopyridines include ticagrelor and cangrelor. Ticagrelor is used 90 milligram 2 times daily. Possible side effect, hematoma, gastrointestinal bleeding, subcutaneous hemorrhage, sometimes dyspnea. Cangrelor is one of newest agent, strong and fast acting for IV introduction. These are blockers, agent blocking purine P2Y12 receptors for adenosine diphosphate. Antagonists of glycoprotein to B3A receptors. Once again, these are receptors for fibrinogen. The prototype is apiximab. Apiximab. MAP means monoclonal antibody. So this is chimeric monoclonal antibody composed of the human immunoglobulin joined to the Fab fragments of a murine monoclonal antibody directed against the GP2B3A receptors. After intravenous infusion, the agent acts for 24 to 48 hours. The most characteristic side effects are bleeding, especially if the drug is used with anticoagulants or if the patient has a clinical hemorrhagic condition. Monephrine. This agent is fragments of monoclonal antibodies. After intravenous bolus introduction, acts for 2 to 3 days, up to 72 hours. Synthetic agents, eptifibatide and tirofiban. Eptifibatide, synthetic cyclic heptapeptide that binds to GP2B3A receptors at the site that interacts with fibrinogen. After intravenous infusion, acts for 4 hours. The most characteristic side effect is bleeding. And tirofiban, tyrosine derivative, binding to the same site as eptifibatide. It is used intravenously by drops. Also can cause bleeding. The next group, agents increasing level of CMP in platelets or PDE inhibitors. Dipyridamole, a coronary vasodilator. Elevating level of CAMP decreases calcium concentration that stabilizes inactive GP2B3A receptors and inhibit release of granules containing platelet aggregation agents such as adenosine diphosphate, serotonin, and thromboxane A2. In combination with warfarin, dipyridamole is effective for inhibition embolization from prosthetic heart valves. Characteristic side effects are transient facial flushing, tachycardia, headache, allergic skin rashes. Xylostazole inhibits PDE type 3, which prevents the degradation of CAMP, thereby increasing its level in platelets and vascular tissues. It is used to reduce the symptoms of intermittent claudication. Possible side effects are headache, diarrhea, abnormal stools, dyspepsia, abdominal pain. Analogs of prostacyclin or agonists of prostacyclin receptors. Prostacyclin or prostaglandin I2 is synthesized by intact endothelial cells. It binds to platelet membrane receptors, causing activation of CAMP synthesis. Elevated level of CAMP decreases calcium concentration that stabilizes inactive GP2B3A receptors and inhibits release of granules containing platelet aggregation agents. The most widespread agent is iloprost. Iloprost is synthetic analog of prostacyclin PGI2. It suppresses the aggregation, adhesion, and activation of platelets, causes dilation of arterioles and venules, reduces the increased vascular permeability, activates fibrinolysis, inhibits adhesion and migration of leukocytes after endothelial damage, reduces the formation of oxygen-free radicals. It is used in peripheral vascular disease, obliterating endarteritis, intermittent claudication, and Raynaud's disease. Anticoagulants. Anticoagulants are medicines, remedies inhibiting process of hemocoagulation. This is also cascade process, final stage of which is formation of fibrin clot from fibrinogen. This is last stage. Transformation of fibrinogen into fibrin, which forms the clot. The enzyme activating this process is the second factor. Second factor is thrombin. Second is prothrombin, but second activated is thrombin. So if prothrombin becomes thrombin, fibrinogen becomes fibrin. But for activation of prothrombin to thrombin should be interaction of several contact factors: 11A, 9A, 8A, tissue factor 7A, and so on. All of these activate the 10th factor, and 10th factor together with 5th activate prothrombin to be transformed into thrombin. Classification of anticoagulants. Classification. First of all, indirect thrombin inhibitors. Once again, thrombin is second A factor. So indirect thrombin inhibitors. These agents, all of them, are used parenterally and include unfractionated heparin, low molecular weight heparins, or fractionated, and heparinoids, sulodexide, danaparoid, heparinoids. Second group, direct thrombin inhibitors. They are used mostly parenterally: hirudin, lepirudin, bivalirudin, argatroban, melagatran. And one of them, the latest, dabigatran, is used orally. Direct thrombin inhibitors. The third group, indirect factor 10A inhibitors. This is fondaparinux, used parenterally. Fourth group, direct factor 10A inhibitors, used orally rivaroxaban, and apixaban. Fifth group, anticoagulants used in vitro. Used in vitro. For what do we use in vitro? For preservation of blood, for hemotransfusion, or for investigation of blood. Used in vitro is heparin for preservation, and calcium complexing agents, sodium citrate, sodium oxalate, and sodium edetate. Sodium citrate is used for preservation, but sodium oxalate and sodium edetate for investigation. All these five groups belong to so-called direct anticoagulants. Direct, because they interact with coagulation factors in blood, directly act on factors of coagulation. But we distinguish one more group, indirect anticoagulants, which inhibit synthesis of coagulation factors in liver. By the physiologic function, these are antagonists of vitamin K. Vitamin K. The basic function of vitamin K, menadione, phylloquinone, is synthesis of protein factors participate in blood coagulation in liver. So these agents, indirect anticoagulants, are antagonists of vitamin K. Among indirect anticoagulants, we distinguish chemical subgroups, coumarin derivatives and indandione derivatives. More often we use coumarin derivatives. These are warfarin, acenocumarol, ethyl biscamocetate. The classical agent is warfarin. Short break. Let us continue our lecture, the second part of our lecture. So, anticoagulants include direct, several groups, and indirect. First of all, let us look at what factors do they act, direct and indirect. Heparin, dabigatran act on second factor, prothrombin. Warfarin on synthesis of second factor. Warfarin on synthesis of seventh factor. Warfarin on synthesis of ninth factor. Warfarin on synthesis of tenth factor. But direct anticoagulants interact directly with 10th A factor. Protein C and S. Warfarin inhibits synthesis. And plasminogen. Plasminogen, thrombolytic enzymes, and aminocaproic acid interact with plasminogen. First of all, unfractionated heparin. Unfractionated heparin. Look, it belongs to indirect thrombin inhibitors. Indirect thrombin inhibitors. Unfractionated heparin is a mixture of straight-chain anionic glucosaminoglycans, sulfated mucopolysaccharides, produced by mast cells with a wide range of molecular weight, 5,000 to 30,000. It is extracted for commercial use from porcine intestinal mucosa. It is dosed in units of action, Mechanism of action of heparin. It binds to antithrombin 3 that catalyzes its inhibition of thrombin factor second A, factor 10th A, and some others about thousandfold. Heparin also directly inhibits thrombin. So we said that it belongs to indirect inhibitors of thrombin, mostly yes, but a little inhibits thrombin directly. Route of introduction, parenteral, or intravenous or subcutaneous. Therapeutic use. We use heparin for treatment of acute venous thromboembolism. These are deep vein thrombosis, pulmonary embolism. For prophylaxis of venous thrombosis after surgery and in patients with acute myocardial infarction. Adverse effects. Bleeding. Monitoring of activated partial thromboplastin time, APTT, is required. Laboratory monitoring. In bleeding, we should know that there is chemical antagonist protamine sulfate, which is used 1 milligram for 100 units of heparin. Can be allergic reactions, chills, fever, urticaria. Sometimes heparin-induced thrombocytopenia. And heparin can be replaced by argatroban, but not by low molecular weight heparins and fondaparinux. Argatroban. There are non-clotting properties of heparin, which we should know. Heparin has an anti-atherosclerotic effect, increasing the release of lipoprotein lipase, which hydrolyzes triglycerides in VLDL, very low density lipoproteins, and suppresses the proliferation of smooth muscle cells. Inhibits hyaluronidase and reduces vascular permeability, providing an anti-inflammatory action. Inhibits the synthesis of aldosterone and causes hyperkalemia. Increases the activity of parathyroid hormone, which can provoke bone resorption in long taking, can reduce platelet aggregation and therefore lengthen bleeding time, has a stimulating effect on fibrinolysis, causing the release of tissue plasminogen activator from the endothelium. So you see that mechanism of action of unfractionated is associated with inhibition mostly antithrombin 3 and a little thrombin comparatively low molecular weight heparin interact only with antithrombin 3 So low molecular weight or fractionated heparins are molecules with molecular mass 4 to 5,000. These agents include nitroperin, enoxaparin, dalteparin, tinzaparin. Mechanism of action sharply increases inhibitory influence of antithrombin 3 on thrombin, and also factor 10A. But unlike unfractionated heparin, doesn't act directly on thrombin. So difference doesn't act directly on thrombin. In comparison with unfractionated heparin, have equal efficacy, and fractionated and low molecular weight heparins equally effective as anticoagulants, but to a greater extent, approximately 2 to 4 times stronger, inhibit the activity of factor 10A than factor 2A, since most or low molecular weight heparins fractions consist of short polysaccharide chains containing less than 18 saccharide units. That is why. Have greater bioavailability when administered subcutaneously, 90% or more, up to 100 versus 20 to 30% for standard heparin. With the same route of administration, subcutaneous, they act longer than the standard heparin preparation, which allows them to be administered 1 to 2 times a day. Heparin is administered 3 to 4 times. And to a lesser extent, they bind to blood plasma proteins that neutralize heparin, as well as endothelial cells and macrophages, providing a more stable effect. heparinoids, pseudodexide, and sodium danaparoid. Heparinoids is a mixture of glucosaminoglycans consisting of a fast-acting heparin-like fraction, 80%, and dermatan sulfate, 20%, heparin cofactor 2, obtained by enzymatic extraction from the mucous membrane of the small intestine of pigs. Mechanism of action is associated with the interaction of both fractions. For heparinoids, characteristic are following pharmacologic effects: anticoagulant, profibrinolytic, and angioprotective. The mechanism of anticoagulant action is associated with the suppression of activated blood coagulation factor 10A and 2A, increased synthesis and secretion of prostacyclin, anti-aggregant influence, and a decrease in the concentration of fibrinogen in blood plasma. The mechanism of profibrinolytic action is due to an increase in the blood concentration of tissue plasminogen activator in the lumen of blood vessels and the decrease in the content of tissue plasminogen activator inhibitor in the blood. And the mechanism of angioprotective effect is associated with the restoration of the structural and functional integrity of vascular endothelial cells, restoration of the normal density of the negative electrical charge of the pores of the basement membrane in blood vessels. Heparinoids are used for angiopathies with an increased risk of thrombus formation. Angiopathies with an increased risk of thrombus formation. Direct thrombin inhibitors. We use mostly parenteral drugs, hirudin, lepirudin, bivalirudin, argatroban, melagatran. Hirudin is the prototype of this group. It is produced by leeches. So leeches are used for thousands of years. Parenteral direct thrombin inhibitors are approved for use in patients with thrombosis related to heparin-induced thrombocytopenia. I told you that one of adverse effects of heparin is heparin-induced thrombocytopenia, causing thrombosis. And in this situation, we should use not heparin, not low molecular weight heparin, no fondaparinux, no heparinoids, but we use direct thrombin inhibitors. And one of the latest agents, dabigatran. It used orally. It's very comfortable. Dabigatran is approved for reduction in risk of stroke and systemic embolism with non-valvular atrial fibrillation. Treatment of venous thromboembolism following 5 to 7 days of initial heparin or low molecular weight heparins therapy. Reduction of the risk of recurrent venous thromboembolism and venous thromboembolism prophylaxis following hip or knee replacement surgery. Indirect factor 10 inhibitors. Indirect. Fondaparinux sodium. Fondaparinux sodium. It is synthetic pentasaccharide that by binding to antithrombin 3 changes the conformation of its active center and to a greater extent than low molecular weight heparins accelerates the inactivation of factor 10A, providing an antithrombotic effect. Antithrombotic effect. Does not inhibit thrombin. Does not inhibit thrombin directly. The short chains does not allow it to simultaneously bind to thrombin and antithrombin 3. Thus, the mechanism of action of fondaparinux sodium is close to low molecular weight heparins. Like low molecular weight heparins, it does not affect platelet aggregation. The risk of bleeding is less than with heparin. Immune thrombocytopenia occurs less frequently than with low molecular weight heparin. Osteoporosis does not develop. Unlike heparin, fondaparinux sodium does not bind to plasma proteins, blood cells, endothelium, providing a stable effect. With the introduction of the drug, there is no need to constantly monitor blood clotting parameters, so it can be used on an outpatient basis. Outpatient basis. Injected subcutaneously for unstable angina pectoris, myocardial infarction, for the prevention of venous thrombosis and pulmonary embolism. It is as for fondaparinux, indirect factor 10A inhibitor. Now, direct factor 10A inhibitors. Direct include modern and very popular agents: rivaroxaban, apixaban, edoxaban. All of them are used orally. It's very comfortable, very comfortable. These drugs nowadays are approved for prevention of embolic stroke in patients with atrial fibrillation without valvular heart disease, for prevention of venous thromboembolism following hip or knee surgery, for treatment of venous thromboembolic disease, and nowadays for the prevention of severe forms of COVID-19. COVID-19. This viral infection promote activation of hemcoagulation, causing worsening of patient's condition. Exactly these anticoagulants, direct factor 10A inhibitors, rivaroxaban or apixaban, should be used. Prophylactic usage of these drugs prevent development of severe forms of disease. And one more, these agents don't require laboratory monitoring of the blood coagulation process with prolonged use. And a few words about indirectly acting anticoagulants. I told you that these drugs influence synthesis of second factor, seventh factor proconvertin, ninth factor Christmas factor, tenth factor Stewart-Prower factor, and also proteins C and S. Synthesis of all these substrates factors are inhibited by indirect anticoagulants. These are very potent drugs, but using these agents, we need to control prothrombin time and thromboplastin activated time, because these agents are toxic. Let us compare warfarin, one of the most widespread of indirect anticoagulants, with heparin. By the chemistry, heparin is mucopolysaccharide, warfarin is coumarin derivative. Source heparin is obtained from hog lungs or pig intestine. Warfarin is of synthetic origin. Route of administration: heparin parenteral, warfarin oral. This is comfortable. Onset of action: for heparin, characteristic is immediate effect after intravenous introduction, but for warfarin and other indirect anticoagulants, 3 to 6 days, because action is associated with inhibition of clotting factor synthesis. And for this, it's necessary to have several days, 3 to 6 days. Activity: heparin is active both in vitro and in vivo. Warfarin only in vivo. Mechanism of action: for heparin, it blocks action of factor 10s and thrombin, but warfarin, we discussed, inhibits synthesis of clotting factors. Antagonists used for overdosage: in overdosage of heparin, we use protamine sulfate, 1 milligram per 100 units. In overdosage and prolongation of time of hemocoagulation or bleeding, we use vitamin K preparations. Variability in response: for heparin, limited variability; for warfarin, marked. Laboratory control: for heparin, essential is APTT, clotting time, and for prothrombin, essential is prothrombin time. Essential. It's very essential to control prothrombin time. Drug interaction: for heparin is not so significant. For warfarin, can be with many of drugs and significant. So using warfarin, we should be very attentive if we administer another drug. And heparin is used to initiate therapy, but warfarin can be used for maintenance on the second stage. On the second stage. For today, the lecture is over. Goodbye.